100% understand where you're coming from. The episiotomy pendulum has solidly swung the direction of episiotomies are terrible and they should not be done. And I also belonged to that camp for a long time until I changed my mind because of research. So let's get a few things straight. Routine episiotomies are not encouraged. They're not encouraged by general OBGYN guidelines. They can absolutely increase pelvic pain, dyspareunia or painful sex. They can cause issues with pelvic floor function. So routine episiotomies are not recommended by pretty much anybody. Also, midline episiotomies, which are episiotomies that are straight down the midline right here, are also not recommended because they can increase the risk for severe perineal tearing or tears that go partially through or all the way through the anal sphincter. But because people are human and there are nuances to everything, we do need to consider some specific situations. For example, when people are having operative vaginal deliveries, when they are having to deliver with ventouse or forceps, the use of episiotomy can actually significantly reduce their risk for severe perineal tearing. There are some people that are just at higher risk for needing an operative vaginal delivery. Things like having a shorter perineal body, having type 2 diabetes, being of Asian ethnicity can already significantly increase your risk for severe perineal tearing, and there are certain things that increase people's risk for needing an operative delivery. And in those situations where it's your first baby and you are needing to use ventouse or forceps to get your baby out, this study found a 49 to 68% reduction in severe perineal tearing when a medial lateral episiotomy was used. Now, this means that they are cutting away from the anal sphincter, partially off to the side. Should all episiotomies be done with the patient's consent and knowledge of what's going on? Absolutely, 100%, always. And we also need to educate people that when there's an operative delivery, there is a much higher risk for grade 3, grade 4 perineal tears, severe perineal tears that could lead to issues down the road, fecal incontinence, pelvic pain, pelvic floor dysfunction, prolapse, etc. And if there is a way that we can potentially reduce that risk during their operative delivery, they need to be aware of that option.